We'll open it for a discussion in the audience. If there are any questions, please raise your hands and very strict to your question. Very briefly direct the question to the panelists.
One of the emerged from Jaffna district. The legal enforcement, we have no power of the tobacco in the NATA, the emerges. So many years we are talking about that. When it's possible to come emerge have an act, this against the 80% implementation of the and other act below the 21 selling and everything. How to tackle in the NATA this issue when it's possible.
Yeah, that's actually exactly correct. According to the NATA Act, the enforcement power is not within the medical officer of health, but mostly it's actually on the PHS. Now actually we are even at actually the period of the Dr. Allen's period, and we were trying to amend the NATA Act to include the MOH into the NATA Act as well, enforcement category. And hopefully again now we are having a little bit of green light for this amendment. Actually it was held for more than a couple of years, which was at the legal department of the Ministry of Health. Unfortunately nothing has been happened, probably due to the various reasons. I'm not going to explain all those things, but hopefully within near future we would be able to amend the NATA Act.
Very good presentation. My question is regarding the addictions when it comes to cigarette smoking. Working in the nutrition space, several patients come and they say they've given up the fact that they can get over it. And even when they come for weight loss advice, they're like, tell me to make any changes except to give up smoking. So are there any professionals or people that we can refer these patients to who genuinely want to get over it but have no help and they feel helpless?
Thank you. It's a very interesting question, and the weight reduction and tobacco smoking, right? So if you look at the objective of weight reduction, basically kind of being healthy or just making a kind of a good appearance or something like that. I mean, so if you stop tobacco smoking, it improves your health. Two individuals who smoke regularly, 2 in 1 people die due to causes of tobacco smoking. The mortality is 50%, right? And if you continue to smoke, you don't look good, right? So that is the common objective you can share. And other thing is, there's nothing called experts creating tobacco dependence. So if you look at the research evidence, more than 70% of them quit tobacco by themselves without any medical support. But having said that, there are effective psychological interventions, right? There are effective psychological interventions. In my talk, that's why I wanted to tell you that it's not the psychiatrist business, it's addiction psychiatrist or addiction clinic business. It won't work like that. There are a lot of people who need support, but it's everyone. It's a nutritionist, consultant nutritionist, right? So whatever the specialty you do, you need to have the basic skills to help your patients out, how to quit smoking, right? So it is interesting to understand few of the concepts and upskill yourself about you need to have some kind of skills to help that individuals, and you will see it's really rewarding. Right? When you see that your patient becomes healthy by reducing weight or kind of adapting to whatever the healthy behaviors. So if you can, along with that, if you can help your patient to quit tobacco, again, it will add on to the results. And it is, I'm telling you, it's not a huge task. You can do that. Anyone can do that.
Thank you very much for the opportunity. I'm Akhil Jayama from KIU campus. So we did research nearly 4-5 years back with National Dangerous Drug Control Board, and we observed a lot of participants, but they stressfully mentioned that most of the young songs, so they endorse this tobacco and the cannabis. So please, I invite you to, so when you are making policies, kindly ban these songs, because they endorse young minds, young people to force on these tobacco products as well as cannabis. Thank you, sir.
Any comments from the panel? Just comments, right? Any response from the moderators?
Actually, even though it is a song, it comes actually under the definition of a tobacco advertisement. So they are illegal. As Sir mentions, there's this complexity in banning social media related content, because they are pretending to be user generated, and they are most of the time uploaded out of the country. We do not have a cross-border advertisement ban, and even if we have such a legislation, implementing it for us like a very low resource underdeveloped country is quite complex. So the strategy is actually for us and the youth to be aware about these tactics, how they are targeted, and be aware of these and be more immune to them. That's a more effective and efficient strategy than trying to have legislations and trying to enforce them, because which are complex. Thank you.
Are there any questions? Any other questions from the audience? Or yes, Professor.
Continuing from what you said, how do you what are your strategies to make them now they are quite immune to this? This is like a social, it's a fad, it's they know all the negative consequences of them, but yet they want to do it because it's within groups and all that. So what are your innovative methods in trying to address that? Because I feel like we have gone too far in our conventional methods. They are not working, and especially with something like digital marketing. How are you trying? How do you plan to counteract such things, especially for young people?
Okay, madam. So because it's pretending to be user generated, even though it's not, they are like $1,000 million based marketing products actually. So the actual strategy that would work is involving young people in counteracting those interventions. So involving them to finding solutions, because it's more applicable for them and they can understand those issues more. And that's actually is quite, as a strategy, we are quite behind in that strategy in the recent times. We were quite ahead of it in early 90s, 2000, when we were doing so well in tobacco control. But now, I think involvement of young people in tobacco and alcohol control, we are not doing as well as we used to do. So I think that's the key.
So in the absence of any more questions, let's move on to the next segment of this panel, this plenary. And so you can introduce the
Thank you so
speakers.
much for the participants for your interactive participation. As we now move into the next segment of our session, sharing of evidence-based insights, we shift our focus to two critical areas of research. You may wonder why. Among many possible topics, why we have carefully chosen these two topics. The answer is more strategic and practical, because we have a time limitation today. We have to adapt to it. So we have selected two significant topics to discuss with you here. The key presentations, and the first presentation will shed light on drug-impaired driving, a growing public safety and public health concern in Sri Lanka. This study presents preliminary findings from a roadside examination conducted by the National Narcotic Laboratory. The presentation is by Ms. Serusi Mahalekam, She is a scientific officer, National Narcotic Laboratory, National Dangerous Drugs Control Board.
Thank you, Sri, and good afternoon, ladies and gentlemen. So I am here to present the findings of the roadside survey conducted by NDDCB relevant to the drug-impaired driving. So this is the outline of the presentation, and we focus on the road traffic crashes for this study, which claim thousands of lives each year in worldwide. So according to the WHO, approximately 1.19 million people die each year as a result of the road traffic crashes, and it leaves around 20 to 50 million people with non-fatal injuries, and 2/3 of these road traffic fatalities occur among the people between the working age. So these have significant impact on the families, individuals, and the nations. So these traffic crashes result severe injuries, disabilities, fatalities, as well as the survivors and the families of the victims may suffer from the emotional trauma, and there will be a loss of productivity, and for the most of the countries there will be a property damages. So healthcare systems and most of the countries have to spend money for the healthcare of these suffering people, and as well as for the property damages. So it is estimated that these traffic crashes cost approximately 3% of their 3% of their annual gross domestic product of the most of the countries. So recently there is a growing concern on drug-impaired driving associated with these traffic crashes, and if a person consumes any drug, then the metabolite will remain in its body fluids, and it can impair the driving performance of a person by impairing the reaction time and the coordination and the judgmental abilities likewise. So it can affect for the central nervous system and the brain of a person and impair the driving performance. So these are the examples of drugs which can impair the driving performance. And so if a person consumes many drugs, we can identify its drug use by using the biological specimens, and there are several specimens we can use for this purpose. Blood, urine, oral fluid, and hair can be used to detect the drug impaired person, and the metabolites will remain for a certain time in a person's body fluids. So based on this, there are several mobile drug testing devices has been introduced to the markets recently. So these test devices are on the spot test and user friendly and can be applied by law enforcement agencies. So most developed countries use these type of test devices for the roadside examination and for the roadside surveys. So oral fluid we can use for testing of drivers at roadside because they have several benefits, which include the collecting and testing of oral fluid is quick and non-invasive, and also there is a limited risk of the adulteration of the sample, and the collection is painless, and testing can be done at the scene, as well as the positive and negative results can take within few minutes, and further the oral fluid gives the recent drug use of a person. So these test devices can use to detect the drug impaired drivers at roadside. So if we come to the Sri Lankan scenario of this, so the increase of traffic related deaths and accident related to the drug impaired driving is becoming a serious issue, and there should be a practicable and solid solution for this or to overcome this challenge. So if we consider the current legislations in Sri Lanka, according to the 151 section of the Motor Traffic Act, it states that no person shall drive a motor vehicle on a highway after he has consumed any drug or alcohol. So accordingly, the legal provisions are available and the regulations are established to conduct breath test to identify an alcohol impaired driver by a police officer using a breathalyzer test. But even though there are legal provisions to identify drug impaired driver using an on-site test, there are no regulations are established up to now in Sri Lanka. So, with the aim of identifying the most effective roadside drug test strategy in Sri Lanka and to identify the prevalence of drug driving in Sri Lanka and to provide necessary recommendations for the amendment of laws and regulation to detect drug impaired drivers, the NDDCB has initiated a pilot study related to the roadside examination of drug impaired driving with the financial assistance of the National Council of Road Safety and with relevant stakeholders. So these are the stakeholders involved in this project: the Ministry of Public Security, Ministry of Transport, Ministry of Health, National Dangerous Drugs Control Board, National Transport Medical Institute, Sri Lanka Police, Department of Motor Traffic, National Council for Road Safety and the government and this department. So before the starting this project, we conduct training programs for the police officers and the medical officers who involved in the training procedure regarding the test device and how to collect the data related to this study. So for the police officers, we conduct a physical training, and for the medical officers, we conduct an online training for the selected officers. So our methodology includes a oral fluid device test conducted by police officer, and the positive results will be confirmed by a government medical officer using a urine test, and the positive results further confirmed by a confirmatory test by a lab. So this is the test procedure we have used. The police officer will observe the drug driving behavior on a road, and he stopped the vehicle. Then he asked to the driver to conduct the oral fluid test and fill the form that we established by NDDCB, and the results will be obtained. So if there is a negative result for the oral fluid test, the driver allowed to continue driving, and if there is a positive result for the oral fluid test, then the driver referred to the nearest government hospital for a urine test. So in that hospital, the government medical officer will conduct the urine test, and if the result is positive, then the sample will send to the confirmatory analysis for the National Narcotic Laboratory. So in this test procedure, we conduct oral fluid test, and it's the technique is the enzyme immunoassay technique. So this is a screening test, and therefore further positive samples were further confirmed by a confirmatory test. So the locations were selected by Sri Lanka Police, the sites within the western and southern province, and the duration was May 2023 to February 2024. So altogether 3,852 number of drivers were tested by Sri Lankan Police, and the test conducted with the consent of the driver, and the relevant data was recorded by the police officer and the medical officer in the form given by NDDCB. So this is the data collection form we have given to them. So it contains all the details of the driver and what kind of driving behavior he performed, and the results of the oral fluid test and the urine test. So these are the types of drugs we have used to detect. So cannabis, methamphetamine, heroin, MDMA, benzodiazepine and cocaine. And the next column shows the cutoff limits of the oral fluid, and the other column shows the cutoff limit of the urine test in these test devices. So these drugs were decided by NDDCB by analyzing the recent trends of drug use in Sri Lanka. And if we come to the results, all the tested drivers were males. Altogether 3,852 drivers were tested, and we got 114 drivers positive in the western province and 28 drivers positive in the southern province. So further we have identified polydrug users around 1.5% from both provinces. So this table shows the drug-wise positive drivers. So mostly we have identified methamphetamine positive drivers around 2.4%, then the cannabinoids 1.5%, heroin 0.9%, MDMA 0.6%, benzodiazepine 0.2%, and cocaine is 0.07%. So this result shows that there is a risk of drug driving behavior in Sri Lanka, and further we have identified some limitations in this project, since this is the first time we are doing this pilot project, and since all the drivers accepted their drug use, so the positive samples were not sent to the laboratory for the confirmatory test, even though our proposal included. So it was unable to determine the difficulties in and limitations in the transportation of urine samples to the lab, because these specimens should have specific conditions for the transportation, so we couldn't identify them, and the project did not represent the whole country because only 2 provinces were tested. So and also details of the driver and the details of the vehicle were not recorded in the form given by NDDCB in every forms. Therefore, we couldn't identify the reliable statistics related to the prevalence of drug driving in Sri Lanka with respect to the age and the type of vehicle likewise. So in conclusion, we can say that this study is an evidence that the oral fluid has a great potential to be applied in Sri Lanka by the law enforcement agencies to conduct roadside drug testing, and the test procedure is reliable to do in Sri Lanka, and there should be new laws and regulations to establish in Sri Lanka to control the driving under influence of drugs. And accordingly, the relevant recommendations were given by NDDCB to the Ministry of Transport for the amendment of laws and regulation to conduct by prescribing the mode and manner which on-site tests needed to be conducted. So for the way forward, we can always conduct the awareness programs for the public regarding the harmful effects of the driving under influence of drugs. And also our research division in NDCB, they started a sociological research related to the drug impaired driving. So authors would like to acknowledge the Road Safety Council because of the funding and all the stakeholders for this project. So these are the references we have used, and I hope that our study demonstrates the potential of the roadside drug testing to detect drug impaired drivers and reduce the risk associated with the road traffic crashes. So thank you all for your attention.
Respond to any questions. Kindly be seated here in case you have any questions from the audience. We have time at the end of both presentations. We'll open it for some discussions.
Our next presentation is by Mr. A.T. Thamanadarshana, Assistant Director Research, National Dangerous Drugs Control Board. The presentation is Community-Based Treatment Interventions for Substance Use Disorders.
Good afternoon, session chair, ladies and gentlemen. So today I will be presenting the topic of community-based treatment interventions for substance use disorders, a systematic review of global models and local practices in Sri Lanka. So there are 2 parts including my presentation. First part is a systematic review of global models, and the other part is local practices in Sri Lanka based on our assessment conducted by the National Dangerous Drugs Control Board. So before moving to my presentation, I will briefly emphasize the terminology, what is the community-based treatment means. Community-based treatment is a non-residential approach to treating individuals with substance use disorders through localized, integrated and client-centered services that involves families, peers and community support systems. So next I will move on to the systematic review part based on the global evidence and global models. So here we have done one of systematic literature review based on the existing evidence published by the WHO, UNODC and some other agencies during 2000 to 2024 with focusing community-based components and implementing strategies and evidence of effectiveness and sustainability. These are the reference that we used during our assessment. Basically, international standards of treatment for drug use disorders collaboratively published by the WHO and UNODC, and the outcome report implemented by the JICA supported project in Philippines, demand reduction project, rehabilitation project, and also the treatment manuals published by the United Nations Office on Drugs and Crime related to the drug treatment procedures. So these are the manuals that we use to do the systematic review regarding the community-based rehabilitation part. So then I would like to emphasize one of service pyramid. Professor Amila Isru was also emphasized this pyramid. Here you can see, according to the service pyramid, the majority of people with substance use disorders fall within informal and community-based care. Only a small percentage require specialized or long-term residential treatment. This highlights the importance of strengthening community-based level interventions where the actual need the highest. So what are the main key characteristics of the community-based treatment? Obviously, it is located in the community, and community empowerment is most essential part of the community-based rehabilitation process. And the other hand is community resources. Community is a pool of resources, so we need to move and mobilize those resources to SUD persons who enroll to the community-based treatment programs. And the other hand, what is the model that we should use within the community-based treatment program? Biopsychosocial approach. So we need health-based approach and also the counseling and psychological approach, and we need to incorporate social and welfare part to this model. And this is primarily an outpatient setting, and the continuum of care is one of essential part of the community-based treatment process, and it should be integrated into community health and social welfare systems. And this should be voluntary enrollment, so we every time highlight and emphasize the voluntary-based rehabilitation within the community system and also to in the residential system, and this is accessible and affordable. So community-based treatment model is designed to help patients to develop skills to manage their dependence-related problems within the community, and they can stop or reduce their drug use through the community-based treatment. And the community-based treatment responds to a wide range of individual needs and ensure the best possible outcomes of the patients. And actively involve local organizations, community members and target population in the establishment of an integrated network of community-based services in the manner that is empowering. And the other hand, reduce the need and demand for residential treatment. As you all know, there is a huge queue and huge waiting list for the residential treatment, as we have limited capacity in the residential treatment system. So we need to have some sort of alternatives. We need to have some sort of evidence-based practices other than the residential treatment models. So we suggest and we introduce the community-based treatment is one of best model to solve this problem. And what are the benefits of the community-based treatment model is this significant decrease in the number of hospital stays and emergency room visits and criminality. And it is flexibility compared to other modalities because it is located in the community. And the community-based treatment basically focus social reintegration from the beginning. And the system of and the method of community-based treatment is support for the family work, day-to-day life and their working life, and also to the social life. And it's opposed to the reduction of stigma related to the substance use disorders, because as you all know, many people do not report to the treatment and rehabilitation services due to stigma. So they always try to hide their problem without reporting to the proper care services. So who are the partners and what are the actions that they need to play within the community-based treatment model? Basically, community-based organizations and community leaders, community members and health services, social welfare services, NGOs, obviously religious leaders and family and supportive network and law enforcement. So they have specific roles within the community-based treatment model to identify needs of the persons who are engaged in the community-based treatment and identify resources to link with the people and to assist to solve the problems and to refer for the other health services or the social welfare services and supported by the experts, and also continuous follow-up is the essential part of the community-based treatment process. So community partnership is one of essential part within the community-based treatment process. As you all know, community is full of resources. So there are several resources and recovery capitals within the community. So in this model, we need to link all the resources and all the capitals with the SUD persons to solve their problems and to reduce their drug use. And these are the treatment components including the community-based treatment models, basically from the screening and assessment and brief interventions and cognitive, behavioral and motivational approaches and family engagement, peer support and recovery networks, and finally relapse prevention and aftercare part. These are the treatment components including the community-based treatment model found through the global evidences and global methodologies. And next I will move to the local practices in Sri Lanka. So this actually based on our preliminary assessment, field assessment we have done through the qualitative approach. So these are our basic objectives to do the field level assessment. One is identify key treatment components and supportive practices, and also explore the role of family and community support systems to the community-based rehabilitation process, and capture feedbacks and experiences from drug users, because several officers are conducting community-based treatment programs in several districts under the guidance of the National Dangerous Drugs Control Board. So we need to have some feedbacks and some evaluation of the treatment programs, and the finally examination of implementation challenges and service delivery gaps. So we selected 59 drug users from several districts who are engaged in community-based treatment programs under supervision of outreach officers of the National Dangerous Drug Control Board, and we do this assessment through the qualitative approach, keeping the ethical concerns. And current practices of community-based treatment by outreach officers, outreach workers island-wide. So basically they are located in district-wise, and also development officers who dedicated for the drug prevention and treatment are engaged in drug prevention and treatment activities in DS levels. So they are also carrying out the community-based treatment programs. And basically they identify drug users from the community and reporting their information, and basically they conducting psychological screening using the WHO Assist V3 screening tool, and based on the Assist results, the drug users refer to the either community-based treatment or residential treatment programs. And key interventions are basically they are doing counseling and individual counseling and family counseling sessions, and continuous follow-up programs with the support of other stakeholders and community partners, and referrals to the some other health services like HIV/AIDS services, clinics and TB clinics, and some other medical services. And our ultimate goal of the all treatment programs to reduce or stop drug use and promote social reintegration within the community. And this is the intervention of outreach officers at a glance. So they identify drug users through the community and reporting information, and they are doing psychological screening and brief intervention part, and based on the results of the psychological screening, they refer to the either hospital-based, inpatient or outpatient, or the residential treatment centers or community-based treatment centers. Finally, they are doing follow-up and aftercare part. So then I will move to the feedback of the clients regarding the community-based treatment parts. So several key highlights here I mentioned for your attention. One is improved functioning of the drug users, because they are locating in the community and they are treating from the community. and family reconnection, because the outreach officers and counselors doing family counseling sessions and families interventions. So with that interventions, they can reconnect their family relationships. And also access and flexibility. The drug users raise their good feedback regarding the access and flexibility. And one concern regarding the they are expecting continuous follow-up from the outreach officers. So when it comes to the overall experience, so positive engagement, personalized care, and motivation to change are the positive feedbacks we got through the assessment. And one thing need to be concerned is that request long-term support from the outreach officers. And the positive observations and active components of the community-based treatment programs. So as positive observations, peer and family involvement is strong, and outreach officers are well accepted in the community members and the drug users and from their families. And drug users prefer non-institutional models because they need to engage their daily life and working life while having their treatment programs. And the active components of these community-based treatment programs, follow-ups by outreach workers and individual counseling sessions and family interventions and community support system. Also the government officials mechanism. As you know that several government officials are located in DS divisions in Sri Lanka. Nearly 30 to 34 government officials are working for the different sectors who assigned from the different ministries and departments. So we need to get their support to the community-based treatment programs to give proper and full-up service to the drug users. So finally, regarding the family and community support networks, so family involvement reduce stigma and promotes recovery. So in this regard, need more empowerment and sensitization. And also the community acceptance supports reintegration. So in this regard also need empowerment and some advocacy part also needed. And volunteers support. So we need to have support from the volunteers. So several districts, they have volunteer teams to work towards the drug-free communities with the involvement of several stakeholders. So they need to have some trainings and advocacy parts to do more to their communities. And DS office enables multi-agency coordination. This should be strengthened furthermore. And local networks and networks sustain long-term treatment impact. So this should be needs integration. So we identified several gaps and loopholes existing community-based treatment programs. One is that we need to have a standardized CBT framework. It's a community-based treatment framework, and minimal service integration. So social welfare service, healthcare services, and law enforcement services are also integrated within this system. And the other gap is that poor documentation and monitoring of outcomes of the community-based treatment programs. So here I mentioned some of the recommendations and proposals to way forward through the global review and also from the national review. So develop a national framework for the community-based treatment programs and formalize the support of partnership of multi-stakeholders and implement digital tool for monitoring of outcomes of the treatment programs and conduct regular impact assessment of the community-based treatment programs. And continuous capacity building programs are needed for the officers who are conducting community-based treatment programs, and introduce legal enactment to formally recognize and validate the community-based treatment program. Actually, in this regard, the Act number 54 2007 is amending these days. So we have already proposed community-based treatment model to include to the existing legal provisions. So finally, thank you very much for your attention.